Good morning, everyone. It is Tuesday and January the 12th. It's 9 a.m. here in Cleveland, Eastern Standard Time. My name is Ashok Agarwal. I'm your host for the next 2-3 hours. And I want to, first of all, before we begin the program, want to wish you a very happy New Year 2021. I wish you good health and a lot of happiness, and I hope that we will be able to see many of you during this year after the pandemic is under control. So thank you again. And today is a very exciting program. We are here to discuss and present virtually our online ART training. Today is the third program in the series. We began in November. We presented first program in November, then second one in December, on December 8th. And today is our third program on January the 12th. Today's program is on Ancillary Semen Test. So let me begin without taking any further time and begin my introduction. Very briefly, this is my biography, a very brief biography, just to provide few highlights. I am in charge of the Andrology Center at Cleveland Clinic for the past 28 years. I'm the director of the American Center for Reproductive Medicine, which is the host of this online virtual training session. I'm a professor of surgery and urology at the Lerner College of Medicine at Case Western. I'm a staff in urology and in some other department. Our group is very well known in the area of male infertility, andrology, and human-assisted reproduction, and we are ranked as #1 in terms of our publications based on the Scopus, which is one of the premier service in terms of the literature in the medical field. Our group has published a very large number of books in the field of male infertility, ART, fertility preservation, DNA damage, and antioxidant. Our laboratory has trained over 3,000 scientists, clinicians, graduates from more than 100 countries. The organizers and speakers of this program have no conflict of interest. We have taken no sponsorship or asked any company for that. This program is made entirely possible by the support from our foundation, from our own center, and the webcasting support has been provided by our colleagues, David Reichling and David Wolfley. Course faculty have generously donated their time for this online training, and our program coordinators, who you will see in a minute, have graciously volunteered their valuable time to manage this program. Lastly, the names, images, and description of products or instruments that you may see during the lectures or which will be discussed during the presentations are not being endorsed. They are being used routinely in our program. So this is today's program. The learning objectives today is we have a very, very good program today, and you will see this is part of the semen analysis, and it is like a hidden gem. Most people will not know many of these tests that are basically done as part of semen analysis as indicated. So we are going to discuss about the leukocytospermia or detection of white blood cell or infection, sperm vitality testing, anti-sperm antibody screening, special test for azoospermia, post-vasectomy screen, and screening for retrograde ejaculate. So I can tell you that today's program is by far going to be the very best. We have invested enormous amount of time in preparing for these lectures. They have been well researched, well prepared, and practiced dozens and dozens of time what you are going to see today. So for each lecture, we have spent almost 30, 40 hours minimum in practice sessions. And each lecture has gone through at least 10 or 12 practice sessions with multiple people. And each content has been well researched through the literature with proper references, and to make sure everything is extremely accurate and simple for you to understand. So this is our program today in a diagram. As you can see, the last lecture is going to be by our clinician, who's going to really put it all together to explain what these tests really mean to you, which is on retrograde sperm count. And this talk will again be given by Dr. Sajal Gupta. So Sajal, please keep it short. Because we have one more last presentation by Dr. Neil, which is going to be summing up all the things that we are talking in a clinical interpretation. So please let me just mute myself.
So thank you very much. And this is my presentation on retrograde sperm count. Next slide, please. The learning objectives of this talk are indications to perform the retrograde sperm count and understanding the special conditions for specimen collection, because 2 specimens will be collected here, learn the procedure and reporting of the results, and reviewing the quality control and quality assurance, as well as troubleshooting associated with this test. Next slide. Indications for the test are, firstly, azoospermia. The lack of presence of sperm is an important indication for performing this test. Second is low semen volume. Thirdly, aspermia. So lack of antegrade ejaculation or lack of semen expulsion from the urethra or a dry ejaculate is an important indication. Low sperm concentration. And the last is urological surgery for benign prostatic hyperplasia is known to lead to retrograde ejaculation. On the right side is the phase contrast microscope. The equipments and reagents. Next, please. The most important equipment is the centrifuge, as shown and on the right side, and then the 2 specimen containers that are labeled with semen and urine. So this makes it clear to the patient that, how he has to collect the semen in the semen container and the urine in the urine container. And the third important component is sperm wash media, which is human tubular fluid. And this is what the urine sample has to be collected in, and the other supplies are also listed. Next. So retrograde sperm, the specimen collection. So the first and the most important instruction to be given to the patient is that they will need to collect at the lab. And when the patient is in the lab, the important step is to instruct the patient to urinate without completely emptying the bladder. So partial urination followed by collection of the ejaculate, which is collected in the container marked semen, and then he will collect a semen sample post the orgasm and the ejaculation in this container, which is marked urine and has the pink HTF, which is 9 ml of warmed up HTF, which was kept in the incubator for 20 minutes. Next, please. So here is the retrograde sperm count protocol, the step-by-step procedure. After the specimen collection, the semen sample is placed in the incubator for liquefaction, and at the same time, start the analysis of the urine sample. Before analysis, measure the volume of the urine plus the HTF mixture. This needs to be documented. And on the right side are the 15 ml centrifuge tubes with the urine and HTF mixture. Next slide. So post the transfer of the urine sample into the conical tubes, these tubes are placed in a centrifuge, and then they are centrifuged at 1600 RPM for 10 minutes. And after the centrifugation, next slide, please. The centrifugation has been done, and on the right side is the illustration with the sperm pellet at the bottom. So the supernatant is going to be aspirated, and make sure not to disturb the pellet or the cloudy portion. This supernatant, once it's aspirated, the pellet is reconstituted in 1 to 2 ml of HTF. And finally, note the total volume of the reconstituted sample. So each of the pellet from each tube is reconstituted in fresh HTF and finally pooled together, and the total volume of the pooled sample is recorded. Next slide. And the final total pool volume of the well-mixed urine sample, one would take an aliquot of 6 microliters and load this on a fixed cell counting chamber. So this is examined under the phase contrast microscope. The first step is to look for the presence or absence of sperm, and then if sperm is present, estimate sperm count and motility. The important point to understand here is the final reconstituted urine volume is used for calculation of sperm concentration and total sperm count, which are both reported. And on the right side is an illustration with a centrifugation and aspiration of the sperm pellet. Next. So here I wanted to highlight a study by a group, Mehta et al., and they have examined the significance of post-ejaculatory urine analysis in infertile versus normal men. So the salient findings of the study were, and they had equal numbers of like 70 infertile men versus 70 normal men with a normal semen sample. And the first important finding of the study was that the sperm were found in post-ejaculatory urine in higher numbers in infertile men compared to the controls, and this was significantly higher. And this is illustrated in figure 1 on the right side. And it is highlighted with the red text box. The significant difference, 24% sperm in controls versus 46% in infertile men. The second finding was that low semen volume is associated with higher percentage of sperm in urine. So this is illustrated in figure 2, the relationship between semen volume and percent total sperm in the urine sample, and infertile men are the black boxes. So this is highlighted with the red circle. With the low volumes or even like no sperm sample being produced, there are a higher percentage of sperm that are found in infertile men versus the controls. Overall, the study reports, which is the third significant finding, that severe oligospermia with low semen volume is directly related with high sperm counts in post-ejaculatory urine samples. Next slide, please. The internal and external quality control associated with this test is mainly to be reporting accurate sperm count and motility. And the red text box in the first illustration shows a normal sample which is examined, and manual count motility is performed, as well as the CASA count motility is performed on the same sample, and there is good correlation between the manual values and the CASA values, establishing internal quality control. The second illustration at the bottom is EQC for the sperm count, and this is a sperm motility video captured on a fixed cell chamber, which is provided to us by the EQC agency. And the red circles highlight the first analyte concentration of 19.2 and the second analyte concentration of 22.2. And then these values are compared with other labs, and our values reported in the lab have to fall within mean plus minus 2 standard deviations of the overall results. And then we meet the EQC criteria and establish that the results from the lab are accurate as well as precise. Next slide. Retrograde ejaculation is associated with infertility, and in these infertile couples, sperm recovery can be done from the post-ejaculatory urine, as shown on the first box, and then regulation of the pH and osmolarity of the urine sample will help improve recovery of the viable sperm. And the recovered sperm can then be used for ART, either IUI or IVF. Next slide. So what is the step-by-step protocol of sperm recovery from retrograde ejaculate for ART use? The retrograde urine sample is centrifuged. The pellet is reconstituted following centrifugation. And this pellet is then layered on the gradient media. A gradient wash is performed, and then the prepared sperm can be used in ART. Next slide. As I alluded to earlier, the regulation of urine pH and osmolarity is important of sperm survival. And this study reported infertility and sterility looked at normal subjects, 6 in number, and their semen sample was exposed to different types. The first image shows sperm exposed to unprepared urine, which is the first urine sample in the morning with a very low pH and a high osmolarity. And this study examined the change in progressive motility grade A and B once the semen sample was exposed to the urine sample. And as the first figure illustrates, there was a marked reduction, immediate reduction in motility of 42%, ranging up to 80% in the sample exposed to unprepared urine. The second image illustration reports sperm exposed to prepared urine, and this exposure resulted in retention of motility. So these were men who were given orally soda bicarb in the morning, and then the urine sample was having a good pH of 7.5 and a normal osmolarity of 300, as illustrated here, and will result in retention of motility. So optimization of sperm can result from regulating the urinary pH and osmolarity, as is done for sperm recovery from retrograde ejaculates. Next slide. So my take-home key points are that screening of post-ejaculatory urine is necessary in azoospermic patients with low semen volume. It's important to observe special collection conditions, including intake of soda bicarb to regulate pH and osmolarity. The collection has to happen in the lab. It has to be, the urine sample has to be collected in sperm wash media. And finally, the retrograde urine sample can be processed for potential use in IUI and IVF. And on the right side, you see the technologist preparing a retrograde urine sample. Next slide. So this is our group in front of the Andrology Center at the Cleveland Clinic, and I thank you all for your attention.
Thank you very much, Sajal, for an excellent presentation. You can connect with our program by connecting on our LinkedIn, and these are the benefits. Almost every single day, we provide update on our research activities by posting hundreds of research articles freely, completely downloadable that anybody can read. We also post the latest research which are presented at prestigious meetings such as ASRM, ASHRI, and AUA. You can learn about our virtual research opportunities, which we have just started. You can learn about our online training and opportunities to collaborate with our team. Just go to the LinkedIn and send a request to Ashok Agrawal, and it will from Cleveland, and it will come to us, and we will allow you to connect to our program. This is actually the best way to learn all the advances that are happening